So bilirubin is physiologic to an extent, and it becomes a severe hyperbilirubinemia when the levels exceed a normal range. So it's interesting to note that a level of more than 17 milligrams per deciliter or 291 micromoles is seen in 1 in 10 babies. So it's a fairly high number, and this is usually the treatment cutoff, though the low risk babies don't get started at this level. In clinic practice, most clinicians and the AAP guideline also suggest that where in concern you can start 20 to 50 micromoles below the threshold mentioned on the AAP charts. So that would come in this range. When I was training, 20 milligrams per deciliter was the cutoff for exchange transfusion. We didn't differentiate the well babies from the babies who might be sick and hemolyzing. So this more than 20 milligrams per deciliter cutoff is very important, 342 micromoles per liter, and it indicates severe jaundice. The frequency drops from 1 in 10 for more than 17 to 1 in 70, and many of these are pathologic. So that's the reason most of phototherapy charts advocate phototherapy at this stage. Of course, it's not common to see babies with more than 25 milligrams, which goes to very high levels, and we start getting features of brain injury beyond that level. Of course, the proportion of babies who get brain injury at this level is not high, but you do run a risk, especially in the growth restricted babies or in the premature babies. So the number that where it reaches more than 25 milligrams is 1 in 700. The really hazardous level is more than 30 milligrams per deciliter or 513 micromoles. Most of the babies would need exchange transfusion when it touches this level, and if they have features of brain injury, you would need to rush into exchange. This is luckily very rare. It's 1 in 10,000 live births. So this is the group of babies where you get kernicterus in the developed countries when they were discharging early on, and that is why most of the current tools that we use, the screening for bilirubin at discharge, the repeated checks and so on came in. So we want to avoid babies going to this 25 and 30 milligrams. So you can see what a big difference it is, 1 in 700 to 1 in 10,000. So more than 30 is definitely very, very abnormal. We should not let it go to 25 because some babies may start getting brain injury at this level. And more than 20 is usually the threshold for treatment in a well baby with non-hemolytic jaundice. But very often we start at more than 17 because we are sometimes not clear about whether it's hemolytic or non-hemolytic, and it's safer to treat than be worried about it as well. There is also a very important factor, which is the impact of gestational age on the jaundice risk. So even though we say more than 37 weeks is full term, you can see that the 95th centile for the jaundice is really high at this stage. It starts dropping. So 36 and 37 week babies are at quite a high risk of significant jaundice, of bilirubin reaching. So this is the percentile. So the 95th percentile and 75th and so on. So you can see clearly that the rate drops very significantly beyond 38 to 39 weeks, and in 40 weeks and above it drops quite to reasonably low level. So less than 10% of the babies would have bilirubin crossing this level physiologically. So it's very important that the obstetrician tries not to deliver the babies before 38 to 39 weeks, not only for the respiratory problems but also for the bilirubin risk.